am Amanda Perez, and I am with the Center on Brain Injury Research and Training here Eugene, Oregon at the University of Oregon. We are so excited to have Dr. Jimenez with us today. So Nathalia Jimenez is a pediatric anesthesiologist at Seattle Children's Hospital and a UW Associate Professor of Anesthesiology and Pain Medicine. She is also a core faculty member at Harborview Injury Prevention Center, where she conducts research on traumatic brain injury among vulnerable pediatric populations. And she's also a new research director for the Latino Center for Health. Just as we're getting ready, we are so excited to have her talking about this. We want to hear from you guys. So please do make sure as you have questions that you put those into chat and Q&A. I'm going to be monitoring those as we go along. So we do want to make sure that we have that. And I'll save them for the end as we go through. So with all of those little housekeeping things said, I'm going to go ahead and turn it back over to Dr. Jimenez. Thank you so much.
Amanda, thank you very much for the kind introduction, and very excited to share with you today. Hello, everyone. So yes, as Amanda said, I am a pediatric anesthesiologist, but my research is primarily on outcomes after traumatic brain injury for Latinx children. I'm going to be using Latinx and Hispanic interchangeable depending on what type of the studies I'm presenting. And today I am going to talk about rehabilitation after traumatic brain injury for Latinx children and adolescents. And I specifically want to talk a little bit about the role of the schools and other support systems to help with this. Some of the research studies that I will present today had grant support from the National Institutes of Health, funds from the Center for Diversity and Health Equity at the Seattle Children's, the Brain Injury Alliance of Washington, and the Washington State Department of Health. So just to remember, the idea today is to identify barriers to access and adhere to outpatient rehab after traumatic brain injury for Hispanic children. I also want to describe some of the facilitators. I think that sometimes we just focus so much on the barriers, but I think there are very important facilitators that we can build upon on. And then I would like to highlight the importance of the school to support community reintegration and outpatient rehab for children. The way I am planning to do this presentation is I think I will go through 3 different sections. First, I'm going to do a little bit of background and briefly delineate the problem. I will specifically talk about known disparities in disability for Latinx children after traumatic brain injury. And I will use a population context. Basically, we know that this is a problem, but how big of a problem? Then, as I said before, I will talk about barriers to access and adhere to care. And the most interesting piece for me is, can we do something about it? And I will talk about facilitators to care. I will share with you some of our experiences with a culturally responsive program, and elaborate in one study in which we look at the role of the schools in TBI rehab for Latinx children. To do this, I'm going to use a case study. I think it helps us to contextualize some of this information, to think about specific patients or specific children. This case study, it's actually a grouping of characteristics of different patients that participated in our pilot program. So all of the situations are real, but this is not a real patient per se. So this is a case of a 16-year-old adolescent who was in a motor vehicle crash as a driver. She was driving by herself, and this crash resulted in a severe traumatic brain injury. She was brought to the hospital in ambulance and required several surgeries, including neurosurgery a couple of times. She was in the ICU, in the intensive care unit, for 3 weeks, of which one of these weeks was on the ventilator, on mechanical ventilation. And then after that, she was transitioned to the pediatric ward in the trauma hospital, and then sent to the pediatric inpatient rehabilitation facility for 1 month. After almost 2.5 months of treatment, she was discharged home with limited mobility, with speech and cognitive impairment, and requiring, as an outpatient, weekly PT, OT, and speech therapies. So how are we thinking about this patient? Would she have a good outcome after the traumatic brain injury? Is this going to be different for her that is Hispanic? So this is the first study our research group did. And what we did is basically just to look at a cohort of almost 500 patients who had traumatic brain injury, from mild complicated to severe traumatic brain injury. And as part of that group, we have a small group of Latinx patients. And when we look at them, we'll look at some of their quality of life at 3 months, at a year, 2 years, and 3 years. And we also look at functional skills for these children. And I am bringing here only the results for quality of life, and this is health-related quality of life. And if you see, these are non-Hispanic white children, and these are Hispanic children, and these are non-Hispanic Black children. This is the difference. So at baseline, all of them look really similar. But 3 months after the traumatic brain injury, all of them had decrease in their quality of life, but the decrease in the quality of life for Hispanic children was really, really large. It was 15 points less. And then what I really want to highlight here is after a year, both non-Hispanic white and non-Hispanic children start to recover a little bit, but Hispanic children will not. And what happens is that these gaps continue to perpetuate over time. And when we look at skills in communication, in self-care, in quality of life, in participation in activities, that was pretty similar. We also look at what happens with rehabilitation. Does Hispanic children recover the same way, or do they recover differently? And the good news is that they recover at the same pace and have similar gains compared to non-Hispanic children when they are in inpatient rehabilitation. So we look at scores in WIFM and MFM and inpatient rehabilitation facilities for 10 years. And we compare again Hispanic children against non-Hispanic children. And what we saw is that they recover at the same pace. So the good news is that they respond, and the bad news is that probably the disparities start to develop after discharge. And if you remember the study that I showed before, we don't have discharge scores. We have scores 3 months after the TBI, but we don't know, in that particular study, we didn't know how were the patients discharged. When we look at what happens after the patients get discharged, what we found is that, especially among Medicaid children, only 29% of these children received any outpatient rehabilitation, and we were including being followed up by a rehabilitation physician, having PT, OT, or speech therapy. And this is important because 62% of these kids had moderate to severe TBI. And these are all kids that have Medicaid insurance. So it's not that they don't have insurance, but despite the fact that they have insurance, there is not only a very small proportion of them continue to receive rehabilitation services. We also found in that particular study that Hispanic children have lower rates of speech therapy in addition to the overall lack of receipt of services for the entire Medicaid cohort. So I want to pause here for a second and talk about social determinants of health. And social determinants of health were something that we didn't consider too much in healthcare up to a couple of years ago. Now, fortunately, more and more we are talking about those. But just to remind ourselves, social determinants of health are those resources such as food supply, housing, economic and social relationships that support the health and the health care of individuals, but that unfortunately their distribution varies across populations. And this is the CDC model of social determinants of health. And if you see, these are some of the aspects that are considered, that are neighborhood and building environment, and we have housing here. We have access to care, and the one that we always think is, do they have insurance or not? But what about access to primary care? Do they have a primary care physician that is taking care of them in an ongoing basis? What about health literacy? Also, we talked about the social and the community context. We talk about education, and in education, we talk about language and literacy of the individuals and about economic stability. And I am sharing with you this slide that is actually courtesy of Dr. Molly Fuentes, that I'm sure a lot of you know, because it really helps exemplify what our patients feel sometimes. So this is the same social determinants of health, right? So we have neighborhood, we have economic stability, we have education, we have access to healthcare, and we have community context. But when we think about this and then move on top of that, some of the systems that are in place, right? So our housing depends on housing policies, and the possibility that parents have a living wage depend on labor market practices, and the quality of the education of the child depends on how education systems are built upon, and access to care, it is the result of healthcare systems nationally, and social support, it's and social support systems are really embedded in this idea of justice systems and immigration systems, in particularly for Hispanic communities. And if you think about those factors in a bigger context, which is the context of the attitudes of the society and the systems, then you start to think about what are the attitudes in our society in terms of the ability of individuals, in terms of discrimination, either at the institutional level or systemic level. What about the gender? And I put this as a girl patient for a particular reason. And what about class? So when you start to think about the social determinants of health, what I like about this slide that Dr. Fuentes shared is the fact that there is this bigger social and economic world that we sometimes do not consider when we're thinking about our patients. So going back to our patient was discharged, as I said, with PT, with a formula for PT, OT, and speech therapy to do once a week in the community, to come back to us to rehab in a month, to evaluate how she's doing for school return, and obviously with follow-up visits with neurosurgery and orthopedic surgery, all of those at Seattle Children's. And then let's think about this family in relationship with social determinants of health. So they live in a semi-rural area, around 2.5 hours from the hospital. Both mom and dad work. However, after the TBI, now mom is working only part-time because she had to shift a lot of her responsibilities to caregiving now. In terms of healthcare, the patient is covered by Medicaid, which is great, but she doesn't have a regular PCP because she was a very healthy girl before, and the parents didn't have that continuity of care. She was enrolled in Medicaid through our social work department at the trauma hospital. In terms of education, mom and dad are both high school grads. Dad is English proficient and mom is an English learner. And in terms of the family context and support systems, this patient has 2 younger siblings. Both mom and dad are immigrants from Colombia. They do not have family support close, but they have a very close community network through their church. So this is a map of the trauma and the rehab services for our state. And the only thing that I want to point out is that, as you can see, there are very few there is only one level 1 pediatric trauma center, and there are very few rehab centers, and there is only one, which is pediatric, and this family lives 2.5 hours north of our center. So every time they have to come to rehab, they have to drive this 2.5 hours or 3 hours to come to us. What about access? So this is a study from our research group in terms of therapy clinics and the accessibility of these clinics for patients in the community. So this is a study actually from Dr. Fuentes, and what they did is that they called different clinics and they asked if they accept private insurance or Medicaid, and they also tried to see if they have language access for the families. So what they found is that PT clinics were more likely to accept, 30% more likely to accept private insurance than public insurance. And this was higher, 40% for OT and 42% for speech therapy. Rehab, there was no difference. So for our particular patient, she was on Medicaid, so you can start to see some of the difficulties in access for her. They also look at the difference in wait time. So when the appointment was given, so the difference was around 4 business days for PT clinics, 15 days for speech therapy, and there was no difference for OT or rehabilitation clinics. Also, if you try to go to a multidisciplinary clinic in which OT, PT, speech services were all together in the same place, so they don't have to be going to different places, it was 59% longer if you're trying to do PT versus 18% for OT and 100% more for speech therapy. So we were trying to understand, and this is a study that we did in our research group, in which we were trying to understand what was the experience of the parents in terms of rehabilitation care, and these are all, we have Latinx and non-Latinx parents, and of the clinical providers. So we conducted in-depth interviews and focus groups with parents of children who sustained a TBI and were hospitalized at Harborview Medical Center in 2015. And we also talked to their clinical providers. We talked to physicians, we talked to therapists, to nurses, to discharge coordinators, both at Children's and at Harborview. And we were trying to understand what were the barriers and the facilitators for accessing and maintaining care. We ask about, when we talk to parents, we ask about their understanding of the injury and the treatments. What were some of the recovery expectations? We asked them about how was transition of care, how was the need and the use of resources in the community and in school. And we also ask specifically about barriers and facilitators for outpatient care. Well, this is not really nice. So I just want to show some of the characteristics of the Latinx parents, and I don't know if you are able to see, but the reason I want to show is that we only had, this is a qualitative study, so we had 15 Latinx children, and a couple of things that I want to point out here. So first of all, 40% of these children were less than 5 years of age. Latinx children tend to be younger at the time of the traumatic brain injury when they are compared to other populations, and this is important in terms of prognosis. Then we also look at limited English proficiency of the parents, and 73% had limited English proficiency. We'll look at place of residence, and half of them were urban and half of them were rural areas. But then when you look at insurance, most of them, 66%, were in Medicaid or any type of public insurance. And here we have severity of injury. This, I think it's, they are more likely to have severe injuries, but of course, these were patients that we recruited at a trauma hospital. So it's not surprising that the severity of the injury is very high. And 4 of them went to inpatient rehabilitation. So when we ask both Hispanic and non-Hispanic families, what are their expectations for recovery? All of them have very high expectations for recovery, and they were very similar. All parents highly value continuing with their child's education and assuring independence. And this was across the board. So to exemplify or to talk about the importance of a school, all of the parents are looking forward to reintegration of the child to the school system. When we ask about their understanding of injury and treatments, definitely non-Hispanic white parents had a better understanding of injury. Specifically, they were able to describe a specific injuries. They say, my child had diffuse axonal injury or had intracranial hemorrhage. So there was more a specificity, I'm sorry, when describing the injury. While with Hispanic parents, they say like, oh yeah, they had a traumatic brain injury, but no more about that. They were also, when we ask about specific treatments and therapies, it was apparent that some of Hispanic parents were not able to identify the differences between the specialists that were seeing the child and the type of therapies that the child was having. And when we ask about their PCP, most of the non-Hispanic white children had their PCP, and the PCP actually had a very important role in helping understand continuity of care for the TBI. Some things that we found unique to Hispanic parents were problems transitioning to outpatient care related to provider availability. And again, it's this idea about needing a provider that had Medicaid and provider service provide language access to them. It's very difficult for them to find them. They had issues with scheduling, primarily because of language barriers in insurance coverage. And some of the parents talked about limitations in access to assistance programs due to immigration status. 2 of the Hispanic families that participated in that particular study talked to us about their need for legal assistance when talking to schools, when they were trying to get some support services in the school. And they talk about poor communication with the school systems, in which they felt that the schools didn't encourage or facilitated parental involvement. Interestingly, when we ask providers, the 2 main things were, oh, Hispanic families don't adhere to treatment, and we have very, very high communication barriers. And when we ask families in general, they say they don't adhere to care because it's difficult due to additional barriers. And actually, communication was the number one was not the number one barrier for Hispanic families, since they recognize that when interpreters are available, they are actually very important and effective facilitators for care. They do talk about the lack of written resources as an important barrier. They say they had the interpreter in the clinic when they were discharged home, But then when they got home, most of the paperwork that they were given was in English. So it was difficult for them to remember all the details from the verbal interaction. This is not unique to Latinx families. This is a paper from a different research group, but they ask specifically immigrant families with children with disabilities, not only TBI, what were some of the challenges to access care and what were some of the facilitators. And if you see, there are very similar themes. So they have difficult accessing information, they have difficulty coordinating services, and they had difficulty in finding services that are culturally appropriate for them. And when they talk about culturally appropriateness, they talk about this lack of trust in the service. And if you are an immigrant and if your immigration status is in process, right, this trust is a huge piece. Language challenges were also talked about, as well as the lack of cultural understanding of some of the providers and the parents. They talk about facilitators, and again, the facilitator of cultural and linguistic competency is huge. Integration of services is an important facilitators, and cultural reference points are really important facilitators for immigrant families in general. So in summary for this section, Hispanic children are at higher risk for poor outcomes after TBI. This is a list of known risk factors for disability, and what I want to show here is that these are overrepresented among Hispanics. As a population group, they tend to be younger at the time of TBI, tend to have more severe injuries. They are more likely to be underinsured or uninsured in general. They are more likely to be poor. Parents are more likely to have limited English proficiency or parental education, and they are more likely to live in areas that have less TBI rehabilitation providers. Now, is this like a concern from the public health perspective? I would argue that it should be. Hispanic children are the largest minority group in the United States. They account for 25% of US children. It is also, TBI is a significant public health burden for children in general, but for Hispanic children in particular. So in a report in which parents were asked about significant TBIs, 6% of Hispanic parents reported that their children had a significant TBI. And in a study in which ED visits were looked at, Hispanic children were more likely to come to the ED because of a TBI than compared to other population groups. Now, the good news is that disparities can be addressed, right? Because some of the risk factors are actually easy to be addressed, like TBI knowledge, and we can work on facilitating access to care. From other groups, specifically from experiences with cancer patients and with patients with asthma and diabetes, we know that interventions that combine education and navigation are highly effective in minority populations. So we developed an intervention that combines these two pieces. In blue, you have that piece of education around brain injury. And then in green, we have this component on patient navigation. And the idea is that if we give education about TBI and about support systems to parents, and at the same time, we help them transition to their community after the TBI, they will have not only higher levels of health literacy, but also self-efficacy. They will feel more competent and more empowered to really help their child to adhere to treatment, and they would be better advocates for services for their child, and ultimately this will result in better outcomes for their children. So in terms of education in this pilot program, we develop culturally competent and language competent education materials for these families. This is just a sample of what we do. It's a booklet, so this is like a little picture of that. But I want to show that we have the booklet in English and in Spanish, and it's a mirror version that allows customization of information. The booklet also has information that helps advocate for this advocacy piece for the families. It's patient and family centered. It promotes parents' advocacy and helps to support skill building for the parents. The patient navigator works with the families for 3 months while they transition from the hospital to the community. It helps coordinate care. It helps to track not only the therapies, but how well the patient is responding to the therapies. The patient navigator is bilingual, so it helps bridge this communication need specifically with the schools. And I'm going to talk a little bit about this disconnect between the school and the healthcare system. It also kinds of supports, and it's like a little bit of a cheerleader for the parent. You're doing great. And it facilitates the things that are very easy, but that are very necessary, such as transportation. And we do that in an iterative way. So we help the parent to get used to this type of thinking. And then after 3 months, the parents graduate and we evaluate how they are doing. So when we did this, the first thing that we were very happy to see is that all families completed the 3-month program. And if you look at the type of interventions that the navigator did, they help with education of the parent, with problem solving, with communication with the schools, coordination of care, transportation, and appointments is when it's not care coordination, but it's a single appointment. And we ask the families that this person that helped you manage your child's care over the last 3 months, did they know about the care needs? Did they not about what the child and the other providers knew about your child? Did they support your decision? So we ask all of these things. And as you can see, the scores that we got for that were very high. There is only one score that is relatively low, and it's help you to get special medical equipment. And the reason for this is that we help with very few of those instances, not because they were not, the families that use that service, they were very pleased with the service, but not all the families needed that service. When we asked about the education materials, we were very pleased that the education materials, that all the families still had those, that the materials were felt that they were useful after discharge. If you remember, some of the families said, we don't have written materials to go back and to refer to the information. These ones are in Spanish. We use low levels of literacy in general. They have lots of images. And they really felt that the information was really to be it was easy to understand the information, and it was very helpful for them. And here, one of the things that was very important for us was this part of skill building and support, and making the parent the advocate for the child. And if you see, it says, did you feel that those questions enable communication with your provider and with your school? And 71% of the parents rated that it was good. Of course, not everything was perfect. So only 57% of these families read all modules, and the rest just read one or two of the modules. And not all the families use all the resources in the module of resources. We'll look at the final piece for us, which is, did we help them to have ongoing outpatient rehabilitation? And what it is good for us is that this, in black, you have the intervention families, and in gray, you have usual care families. And as you can see, going to appointments improved significantly in the research group. So we were very happy to see that having this level of support really helped families to access care. And here we have the caregiving self-efficacy piece. And you can see that parents really, over time, we followed them over a year. They felt that they were more, they had more skills under their belt to care for their children. There is this piece of community self-efficacy that it improved over time, but not as dramatically as the caregiving self-efficacy. And it's hard. If you can see, there were some improvements at the beginning, and then at 6 months, it's this small dip. And the thing is that navigate rehabilitation for the children and support systems is hard. And parents, you know, they have like a slower slope of learning, but I think ultimately they felt competent at the end. And this is health-related quality of life. And differently from the first study that we did, here we measure quality of life at the time of discharge from the hospital. At the time of discharge from the hospital. And as you can see, these kids go out of the hospital with really, really severe limitations. And at 3 months, there is some improvement, and then there continues to be improvement over time. However, it's important to notice that most of the improvement happens from the time to discharge to 3 months after discharge. And for us, and we measure that in different domains: physical function, anxiety, depression, communication, self-care. And this is very important because the first 3 months after discharge are critical for these kids to improve their function. And that's why most of the programs that we are trying to support are over this period of time of 3 months after discharge. So now a little bit about the role of the schools in the last 5 to 10 minutes. So the role of the schools, it's really important. Even the report to Congress on traumatic brain injury that was released in 2014, it highlights this idea that while schools are really, really very important, only 50% of pediatric TBI patients receive this hospital to school transition services. There is definitely a disconnect between the healthcare system and the school system. And the problem is that the person who is making this connection is the parent or the caregiver. And when these parents don't have the support systems or the knowledge to do that successful transition, then the kids are the ones who experience difficulties. So I just want to share with you, this is a study that we use. It is a secondary study of a cohort of 500 children that are less than 18 years of age that had a TBI long ago, between 2007 and 2008. And from this cohort, 74 kids were Hispanic. And what we look is, did they receive school services after the TBI compared to pre-injury data? And then did receiving these school services resulted in improvement in their GPA? And that is the only way we have to see if there is, let's say, academic effects on receiving these school services. And as you can see from the slide here, we adjust for some important characteristics, which is injury severity, the age of the child, the income, and the fact that they had prior school services before, because we know that those are characteristics that affect the outcome. So these are the children that we have in this particular study. Again, I just want to point out that Hispanic children, and in this particular study, we had mild TBIs as well. So Hispanic children were more likely to have more moderate to severe injuries, if you can see here. Again, this theme that they were more likely to be young at the time of injury. They were less likely to have private insurance compared to non-Hispanic white children, and they were more likely to be poor. So all of these risk factors combined in this group of children. Here, we look in the darker purple is the before traumatic brain injury, and then in the light violet, I guess, is the year after the traumatic brain injury. So if you see non-Hispanic white children overall were more likely to have any support school services. Only 5% of Hispanic children had school support services before the traumatic brain injury. And then after the TBI, 29% of them had school services. When you look at receiving IEPs, 16% of non-Hispanic white children had IEPs before the TBI, only 12% of and only 2% of Hispanic children had. After the injury, 12% of non-Hispanic kids had IEPs and 7% of Hispanic children had IEPs. When we look at 504 accommodations, similar trend, less Hispanic kids less likely to have accommodations before the TBI, and then compared to non-Hispanic kids. And in tutoring, again, pre-TBI, Hispanic kids less likely to have it. And then after TBI, actually, Hispanic kids were more likely to have tutoring. So what was the effect of receiving these services after the traumatic brain injury? So this is called predicted because we adjusted for risk factors, but these are actual GPAs of the child. And if you look, the difference between having with and without services for the Hispanic children was higher than for the non-Hispanic children. And what it means is that when we compare those Hispanic children, all of the children that receive services after the TBI, the Hispanic children had a higher change in their GPA, meaning have compared to the ones that did not have services, they actually improved their GPA in a larger degree. So in conclusion, before injury, Hispanic students are less likely to receive services at school. After injury, Hispanic students receive more services than non-Hispanic children, but mainly because of tutoring. If you look at IEP and 504 accommodations, this is not what is happening. And then what is important here is that when Hispanic students received services, they significantly improved their academic outcomes after injury. And here we only look at academic outcomes, but this is really reintegration to their own community, which is the community in the school. So what is the public health relevance of this? This is a little bit old. I don't have more recent data on schools, but this is Hispanic schools, Hispanic students as percentage of total enrollment in the schools. So if you look at that, this is 1996, 2006, and 2016. So there is a trend of increasing numbers of Hispanic students. And I would say that overall, 25% of students are Hispanic, but for some school districts, it's higher than that. So it is important for us to make sure that these students receive the support that they need. This is a little bit of showing you what we have been developing to help the parents. So here, these are videos that we explain to them what are the support systems in the school. And we talked about IEP, we talk about 504 accommodation, but we talk about other support systems such as tutoring and counseling and preferential seating. And basically what I want to highlight here is the piece of what parents can do. So we really try to teach parents that they can help track progress, that they should share information from the doctors with the teachers, that they should ask questions and they should monitor their child, and that they are very key components of their child's recovery. So for our patient, after 3 months in the program, we help them to initiate and sustain therapy with coordination of care, interpretation, communication with the school. The school, we help to provide health information to the school, and the school was very receptive. We were just merely a bridge for the school services. After completion of the program, the parents really have a better knowledge of TBI. They were very able to articulate what's diffuse axonal injury, what is the problem with diffuse axonal injury in terms of cognition and speech and other impairments that this patient had. And I just want to highlight that there were facilitators that were very important. One was the support programs that the community gave to this family, but that the school gave to this family. And in terms of the family, they have very robust support systems in their community. The values that they had, they prioritize the health of this child above all things, and they were extremely resilient. So probably to finish this talk, I think we usually think about vulnerable communities only about the vulnerability, but it's very important to understand that with that vulnerability, it comes extreme resilience and other important factors that help them to advocate for their children and to help them to recover. So I just want to acknowledge primarily the patients and families who participated in a lot of these studies, the team that had worked with this, and the Brain Injury Alliance and other people, other mentors that have worked with me during this time. Thank you.
Thank you so much. That was a fabulous talk. We do have a couple of questions from people as we were going along, but I'd also like to say for anyone else who is still online, this is an opportunity to ask your questions. So please use the Q&A option down at the bottom of your screen so that you can get those questions answered. So this first question is from Christine. She wants to know if you have a sense why Latinx kids tend to be younger at time of injury.
Oh, that's an excellent question. So there are several factors, but I think to answer your question in a better way, so there are two peaks of injury in children and adolescents. So the first peak of injury is around toddler years, in which these kids start to be very mobile and they start to fall, right? And then in adolescence, the reasons for TBI are more related to sport activities and to motor vehicle crashes. So these kids, Latinx kids and other vulnerable populations, they tend to have risk factors for having TBI around the preschool years. So we see a lot of these kids that have falls, for example, balconies and windows in the summer, or that they are in houses in which supervision tends to be more complex because they have more siblings with them. So these are some of the risk factors that they have. They also are more likely to be unrestrained in the cars, like in car seats and in booster seats, unfortunately.
Thank you. And this one is a little bit longer question, kind of related to Oregon, actually. So it says, recently, I believe Oregon permitted us to obtain a TBI school age eligibility for IEP and 504 using a credible report, whereas previously we had to have doctor documentation that was hard to obtain, especially when the injury occurred in another country or state. This person wonders if this was considered school services as part of the study, and also wonders if access to services will increase now that students can access them using a credible report. I know you're from Washington, so I know this probably didn't directly impact you. And we do have new credible history guidelines that are going into effect, I believe this August, if not already. But do you know enough about that to speak to this question?
So I don't know about the specifics, but I do agree with the second part of the question. I think it is in which if I believe that this credible report, new guidelines for credible report would be beneficial or will facilitate access to school services, I think it will, because part of what families struggle is this lack of communication between whatever was the care provider and the school. So I do think that this is a great step to facilitate receiving of resources. The first part of your questions, I don't know if I will be able to answer. I'm sorry.
And fair enough. Different states, different rules and policies. This question is from Alejandra Reyes. Are the educational materials and bilingual education videos available to the general public?
Yes, there are, and thank you for asking that. I actually, we have some posted in our website, but I think these are getting a little bit older, so I'm happy to share with Amanda the ones that we have, the latest version that we have. The Brain Injury Alliance of Washington printed some of these resources as well. So yes, these are ready. The videos are not, because we are testing the videos, but the written materials are ready for the community in English and in Spanish.
Great. Do you think the videos will become ready at some point down the road?
Yeah, that's the plan. Yes, short answer. We're waiting to finish the testing of the materials, but yes, that's the plan.
Okay, fantastic. Well, I will be happy to send this out when I send out our evaluation form. Nathalia, thank you so much for taking the time to do this. We really appreciate it. And for those of you who participated today, thank you so much. Having you participate makes it a richer experience for everyone. So we do appreciate your time taking this out on a Monday afternoon.
Thank you so much. This was really my pleasure.